Good evening and welcome to this webinar where we will talk about the worn dentition and in particular assessing the risk. If you can hear the sound, can you please type your country or your city or something in the messages so that we can tell the sound is coming through. At the end I will answer questions, so if you want to type some questions while I'm speaking you're most welcome to. And for those of you who want your friends to see it or something, the replay link will be on the Academy with all the other webinars that we've done. You'll get sent that link at the end. Now, the worn dentition is a particular type of, a particular style of dentistry because it affects so many teeth. So when we talk about decay or periodontal disease, they can affect one tooth, but when we have wear, it almost never affects a single tooth. By definition, it affects many teeth or the entire mouth. So that's probably the single biggest difference here. Now, one thing about these patients is quite commonly they may not have a lot of tooth decay or periodontal disease. They may do, but they may not. And so it's actually just the wear itself or the tooth structure loss, non-carious tooth structure loss, if you want to be fancy, that we're concerned about. Now, in particular, we want to look at assessing the risk. This is something that when you start dealing with worn dentitions, very difficult to do. Our ability to assess risk comes from training, it comes from knowledge, it comes from being taught, but there is actually nothing like a case going disastrously wrong to give you that caution, that discipline, to calm you down. Because when you're early in your career, you see a worn dentition and you're so excited, you're going to put crowns everywhere, okay? And it's only later that you learn to be more cautious and to take your time both before you start treatment. That's the bit that's probably the most important, the bit before you start treatment, and taking your time after you start treatment. Now, the second thing we're going to talk about is how do we manage these risks? Now, some of it, as you will expect, is technical or clinical, but a lot of it is actually communication before you start. So managing risk actually starts before you do any dentistry at all. My consultation process actually used to be very short. In my early years, it was a little bit longer, and then I had a very short consultation. And then I got into a stage where I actually used to do very rapid consultation and talk the patient into treatment very quickly. And I was very good at it. And if you go to many courses around the world, they will train you on how to sell dentistry very fast and very effectively. Now, doing something like healthcare and being a professional, you actually have to learn, if you're good at selling, to not be so good. That's a very important point. To learn to, well, actually, that's not really the truth. The truth is you need to learn to sell very well. And when you sell very well, you find out a lot about your customer or your patient, and you give them something that's exactly what they need. That's the mark of great sales, okay? Slightly less good is where you get a product and you push it down the patient's throat, regardless of whether they want it or not. So if you give the patient dentistry that they don't really want or is not really suitable for them, you might be good at talking people into it, but that's not great sales. Great sales is giving people really what they need, what they want. There's really three main risks I'm going to talk about today. When we're thinking about wear, we're not thinking caries, we're not thinking perio, we're thinking things like acid. So the first risk we're going to look at is chemical risks. So things that come up and things that go down. So by and large, we're going to talk about acids. Dietary acids and reflux are really the two chemical things. And there's a few others, obviously. There's some recreational drugs and so on that can have quite a big effect on teeth. And also the change of the pH of the mouth. But we'll talk about that more in the biology section. This is a big risk for causing a worn dentition. But in my experience when treating the patient, it's less of a risk to your dentistry. It's less of a risk to your dentistry compared to mechanical issues. So mechanical issues are, these are the ones that we think about more commonly, just the power of the muscles, the patient clenching, just fracturing, breaking crowns off, breaking the tooth off, splitting teeth, screw loosening, splitting crowns. I've had a patient flower 6 implants that I placed. Every single one I placed in him, he managed to flower the implant. So they're the things that we often think of with respect to the worn dentition. They are a big cause of wear. I don't know whether they're more or less than acid, maybe similar, but they are a much bigger risk to our dentistry. Because it's very easy for the worn dentition, after a lot of work, to become the worn dentistry. In fact, it will become the worn dentistry, hopefully not catastrophic or quick. And then the last thing, I won't spend as much time on this, is the biological risks. Okay, we all know that if you're going to do large-scale dental work, you really need to be in control of the periodontal disease and the caries. Now, the range of patients I'm going to show you, not a single one of them is a high biological risk. I won't do complex rehabilitations in someone with high biological risks, so high risk of tooth decay or high risk of periodontal disease. It's just not worth it for them, and it's not worth it for me. No matter how much you tell the patient that things could go wrong, if they go disastrously wrong, you'll still feel sad, and so will they. Now, the patients I see for this sort of thing actually just don't have these issues. Like, they may have had them when they're younger, but they don't have it so much. And particularly in my practice, periodontal patients, they don't progress to any other type of dentistry until their periodontal condition is under control. So they go straight to perio jail and they don't come out until their gums are fixed. Now, I should say that that's not true. I have one patient who I did a rehabilitation on. It was a full telescopic case. And it was done that way because she has periodontal disease and she smokes. And there was no chance that she was going to give up smoking. I said, "Do you think you'll quit?" She said, "No, I love smoking." Trying to tell a person like that to stop smoking is frustrating for you and annoying for them and makes no difference at all. So just don't do it. So she loved smoking. She wasn't going to quit. She could manage the perio. Now, perio and smoking, in my practice, no implants for you. If you smoke, maybe we can do implants. If you have perio, maybe we can do implants. But if you have the two together, no implants, okay? And that's just because I've had cases where I've tried it and it's gone disastrously wrong very quickly. We'll move on, and I'm going to go through a selection of cases, and we're going to look at the risks for each one of these, and some of them are long-term cases, so you can actually see how that risk played out with the patient. This was actually the first, I think it was the first full mouth rehabilitation I ever did. Okay, so this was done really when I had very little idea about anything. I wouldn't have known an occlusion if it came up and bit me. So this patient, I had a little bit of an idea about getting a wax up. I knew a little bit about doing crowns. We had materials back then that weren't so good. We had aluminium oxide crowns, which used to break. They looked pretty, but they broke. They all broke. Just before we had zirconia. So this patient, I think he was one of my last patients to have porcelain fused to, I think it was called Procera back then. It was the original term that they gave Procera to because they were milled using the Procera system from Nobel. Now, if we look at him, when we want to start assessing the risks, we want to start before we go into the mouth. So in my practice, we sit down and we have a talk or a consultation, and I want to know about them. I want to know about those sorts of risks. And I'm looking at the patient, and when I'm looking at him, I'm looking at his face, and in particular, I'm looking at the masseters. Okay. Now, this patient, you can see that he's not a skinny man, but he's not a huge, bulky. He doesn't look like he lifts weights every day either. He doesn't clench while he's trying to look at himself in the mirror to see how much he's lifting and how good his muscles look. He doesn't look hugely fat, okay, but he has decent sized masseters, so he could put some force on his teeth. The other thing I'm going to look at when I'm looking at the face is I'm going to look at the neck. Okay? If you have a patient who is really fat with a big fat neck, there's a very high chance that they have sleep apnea, and so then you're going to ask them. We might ask all our patients a history to see if they have sleep apnea. Do you wake up tired? How's your snoring? Do you stop breathing while you're snoring? Do you get tired in the afternoon? These sorts of questions. If in doubt, send the patient off for a sleep study. In my town, I have to refer them to a general practitioner or to an ENT surgeon. I normally go straight to the ENT surgeons, and I get them to scope the nose to check for deviated septums, the adenoids, tonsils, and any other physical obstruction. A lot of my patients have physical obstructions in their nose, but it's just allergies. There's a lot of allergies in this area. And so many of these patients end up on nasal steroids, and then most of their airway issues are fixed. For those that have sleep apnea, obviously, then we're going to consider either when we're finished or when we start, one or the other, a mandibular repositioning device, or they may get a CPAP machine to blow air in their nose. The compliance of CPAP machines is not so good because not everyone wants to have an air compressor attached to them everywhere they go. So now, why does sleep apnea matter? Because when you have sleep apnea, the intensity of your grinding or clenching, your parafunction, increases. Okay, so if we control sleep apnea, we're not going to go to the patient, well, it's fine. You can stop wearing your bridge, you can stop wearing your splint or your night guard or whatever protection thing that you make at the end. We're not going to say that, but it lowers the risk a little bit. Now, very rarely in dentistry do we get things where we can just do one thing and it fixes all our problems. So it's like when we do a crown prep, there's not one thing that goes on in a crown prep that fixes all our problems. So we gain benefit from lots of little things. So it may be that sleep apnea reduces the intensity a little bit, maybe some sort of bite guard helps protect the teeth, the way we design the occlusion and some of the other risk factors or ways of managing these risks that we'll talk about later. Each one on their own may not matter that much, but it's when we put them all together. Now, strangely, the next point I'm going to bring up was actually first brought to my attention by a periodontist. Brian James is a great periodontist from Cairns. Now, why does a periodontist care about whether a patient is brachyfacial or dolichofacial? You know, do they have a short, square face or a long face? I would say that if a periodontist mentions this, they've done a full arch implant-borne rehabilitation, perfectly done, and the patient destroyed it. I have done a full arch implant restoration in a patient who had big masseters, brachyfacial, so a nice square jaw, low facial height, usually a deep bite. I've done a full arch implant rehabilitation of a patient like this. The patient broke the front teeth off in 3 months. He broke the repair in another 2 months after that. I made a full new prosthesis, which he broke in about 6 months. I made him a porcelain fused to metal prosthesis, which he broke the cantilever off of. I put in extra implants and turned it into 2 separate bridges, and then he sheared the porcelain off. So over a period of 2 to 3 years, I lost about, I don't know, $60,000 on the case. So that is why probably a periodontist has suggested that brachyfacial patients are scary. This patient is not brachyfacial, he's mesofacial, so he's kind of standard. He's not got a really square jaw, short face. He hasn't got a long jaw and a long face. He's kind of normal. So when we're looking at mechanical risks, we'd say his risk is not low. He's not tiny and skinny with tiny little muscles, but it's not off the charts with huge muscles and a square jaw. When we start looking at the teeth, we can look for some more mechanical risk factors. So at that stage, I really was completely unaware of the danger here. So when a patient grinds their teeth, if their teeth are all nice and flat and smooth, everything flows and the forces get put from one tooth to another very gently. It's one of the key parts of occlusion is to have forces move gently over each other and to have things under compressive force, not tensile force. If you have a nice round tooth sliding over another round tooth, the forces tend to stay compressive. If you have very pointy cusps, which you will get if your technician has just gone to a waxing course, or if you've just got a new CAD/CAM machine and you don't know how to change and you're using the fanciest library in your CAD/CAM milling machine, then you might end up with very pointy cusps. And then when the patient grinds side to side, they can put those cusps against each other and they will get tension. In the lower incisors, when they're rotated, then one edge of the tooth will hit the upper incisors before the upper. In fact, you can see the lateral incisor in the canine, particularly that lateral incisor that's rotated. If you look at the upper incisor, it is short. So the upper tooth is short over the crowded or rotated lower incisor. It also means when this patient protrudes that the force will hit the upper teeth one tooth at a time. So it'll hit this tooth and then that tooth. And so all of the entire force of that protrusive function is going to apply to one tiny point on each crown, one at a time. And we'll see how that worked out later. If we start looking at the teeth themselves, do we see a lot of mechanical wear? And the answer to that is not really. Maybe that shiny spot on the amalgam on the distal tooth, we're seeing some wear there. Maybe there's some wear facets on the canines, but there's not actually a huge amount of mechanical wear. This tooth structure loss looks chemical, okay? So we're looking at it, we've really got chemical risk factors here. So we've got tooth structure loss. Obviously, I had to talk to the patient. He didn't really have dietary issues, but when we talked to him, he had massive uncontrolled reflux for a long time before he went on to Nexium. So he now takes Nexium. His reflux is probably still there a little bit. So people who have reflux often still have a little bit of reflux. It's just not raging out of control the way it was before they were on medication. I know a little bit about this because I have reflux. About 40% of the population have a hiatus hernia where part of the stomach sits above or has popped through the diaphragm. And so when you produce acid to eat your meal, then it's going to go up the esophagus instead of down. So 40% of the population are a little bit at risk of reflux just from physical, the physical form of their gastrointestinal tract. So you can see on the upper teeth, areas where there could have been acid attack is very widespread. There's heaps of teeth here. They've got that traditional cupping that happens when you get reflux. And in particular, we've got that wear pattern where the back teeth are really badly worn, the front teeth are not. This is a diagnostic thing. It tells us that this patient is very at risk and most likely the loss of structure was acidic. Now, that's good for us if we're going to rebuild things. The reason it's good is because acid damage to our restorations is much less of a problem than mechanical damage. So yes, things are a little bit more likely to wear and so on, but acid attack on our restorations, as long as the patient doesn't have caries, doesn't seem to affect the patient near as much as mechanical attack. So it's not likely to break things down. Now, the flip side of that is when you see this lower teeth here, you can see that there's actually class 5 lesions on the side, and these are almost certainly a combination of brushing and acid attack as well. So that area is a concern because if you finish a crown just above that area or just at the bottom of it and there is ongoing acid issues, then you're likely to get undermining of your restoration, particularly if you've tried to do a minimal intervention onlay type restoration. I've had this happen to me where I've done onlays. I finished them either just above or just below the class 5 lesion, trying to be minimal, and then the patient has made the class 5 lesion much deeper, and I've ended up with a big undercut underneath, which then became carious, and then I had to change to a full crown that went down subgingival. So from that point of view, it is a concern, but from the actual occlusal portion, fracturing, breaking down, falling apart, it's nicer if the patient had acid issues than if they had just attrition or mechanical wear. One thing I will point out is that if you have patients, I have a lot of patients in this area and who are farmers or who work in earth moving. And these two groups often have a lot of wear because in this area, it's a tropical area, it's very hot, it gets very sweaty. So if they're outside working, they will sweat a lot, they'll dehydrate, and they will get dust. And I think it's the dust between their teeth causing a lot of wear. I've noticed a strong correlation with farmers and with earth-moving contractors, people who work in hot, dusty environments. although, I mean, theoretically they should all be in air-conditioned tractors or bulldozers now, but it's something to look out for. Biological risks. This patient, like many of my rehabilitation patients who have a lot of wear, there's very, very little biological problems. He really has no periodontal disease at all. He could probably not get his teeth scaled for 5 years. Don't tell him this, okay? But he could probably not get a checkup for 5 years and he'd still have no periodontal disease. He had a very tiny area of decay, which, given that he had so much acid going on in his mouth, is probably not a concern or not a surprise. So low biological risks. Now, you might say, why did he actually come to my practice? Well, this tooth with the big glass ionomer cement filling, big GIC, that's actually why. And he turned up, he had toothache. He actually had eroded his teeth to the point that he had exposed the pulp on his lower molar. So he came in with toothache. I did endo. I think it was like my first time using rotary endos or second time. And I'm pretty certain I've only twice in my life, and I shouldn't say this because probably next week it'll happen to me, only twice in my career have I separated a file. And I think separation is just the loveliest way to say, I broke a file off in your tooth. It's like, an execution saying, I just separated his head from his body. So I separated a file, I sent it to the endodontist. He came back from the endodontist like this, and he said, I don't want any more root canals. He hated it. Now, this becomes important later because later I'm going to ask you, was it successful? So if we look at this patient, he's not hugely risky. He's got some risk. His mechanical risk is not low, it's not high, it's kind of in the middle. These things are not mathematical, it's just a judgment. It's like saying, does someone's teeth look nice or they look awful? There's not mathematics that can tell you that. You just look at them and you go, yes, I like them, or no, I don't, or I'm not sure. So, he's got a moderate risk of mechanical issues. His chemical risks were extremely high, but now they're probably under control. So I would say moderate to low. Now, they weren't before. And biological risks are low. He has no perios, no caries. So how did we go with this patient? Now, bear in mind that this is my first rehabilitation. I had no idea. What I did with this patient is I got a wax up done. I made a suck down stent. I did a bonded mock-up over his upper front teeth. So, you think this is all trendy doing this now. We were doing this in I think I treated this patient in 2006 initially. And then I did composite mock-ups over all of his back teeth, which were bonded. And then slowly, because I just had a brand new CEREC, I was very excited to use CEREC for everything. I was heading towards peak CEREC. So I did CEREC restorations on all his back teeth, and I used feldspathic porcelain. Now, people try and tell me that feldspathic porcelain that's manufactured, once it's bonded, is as strong as everything else. And back then, they used to have this theory that once you bonded something to the tooth, it was stronger than a real tooth. So basically, if you did dentistry, you were better than nature or God. You never are, okay? Never think that. This was the first crown that broke. It was the K9, came off about a year later. This is aluminium oxide Procera, cracked through. Another year after that, the lateral incisor went. This is the temporary. I was too sad to take a picture of the broken tooth. Now, if something breaks, I take lots of pictures. But back then, once the patient had a broken tooth, I would sit there. At first, I'd stare at it for about 10 minutes. I was kind of like, if I use the power of the mind, it will go away. And no matter how long I stared at it, it was still cracked. And then I would work out how I was going to tell the patient that their many tens of thousands of dollars rehabilitation is breaking already. And then I'd usually say words inside that you shouldn't say outside. And then, anyway, we moved on. At this point, I was guaranteeing these restorations. So this stuff I paid for. So I paid for the first crown, I paid for the second crown. Then the other front tooth went, the central incisor. So we replaced that one. And then we gave the front teeth a little bit of a break. And this is about 5 years later now. So I think it was the last one I did under warranty. It was too thin, okay? There's definitely thinness issues. It has worn and it broke. So I moved that one to a gold prep and we did a gold crown there. Now, we did have some issues on the lower. You can see that it was all bonded to dentine down here because there was a class 5 lesion and then the feldspathic. So this is more at about 8 years. Once again, became a gold crown. And then another feldspathic porcelain crown fractured on a premolar. It became a full contour zirconia crown. And then this lateral incisor. Now, it's a bit hard. You probably can't see it on the screen, but there's a crack right here. Now, the good thing about porcelain is often you can see a crack in it long time before it breaks. So you have time to prepare yourself and the patient. And you go, oh, a bit of a crack starting there. You may need to replace that in a year or two. So you can kind of soften the blow a little bit. But it's interesting when you look at this, because if you look at where the lower teeth are hitting, one of those curved, rotated lateral incisors on the lower is hitting right there, okay? Right on the crack. So we replaced that one, and it was replaced with full contour Emax. So we did a full contour Emax. It's just stained and glazed. And so this case is now 12 years old. Now, I'm going to point this out to you, okay, for those of you. Now, you'll probably heard me say this before, but for those of you who say that doing a crown has a 20% chance of endo, I have done 26 teeth crowned, and then I think I've done 8 of them a second time. So the patient has now had 34 crowns done. That was the original endo where I separated a file and the endodontist fixed. This endo was done before I saw the patient, and I just want you to behold that there is no endo. So the statistics aren't working very well here. This is 12 years post-op. There's no periapical widening on any of those. Part of the reason is that most of the restorations are quite a long way from the pulp. Now, you could argue that while some of my restorations are a bit thin and they broke, it kept them well away from the pulp, so maybe, I mean, you can sell however you want to sell. You can sell it as a good idea if you want to. The patient probably would have preferred not to have had some crowns break. So that's all assessing risk, okay? That's all very fine, but how do we manage it? This is the bit where that's really important. Now, most of managing the risk, in my opinion, starts before you do any dental work. In particular, telling the patient that repairs are going to cost them money, and can they afford to make those repairs? Can they afford the maintenance of their case? No matter how badly and how excited, once you've done many of these cases, you are not so excited. But when you first learn how to do them, you're very excited and you're trying to find every patient you can grab and do this sort of treatment on, okay? Whether it's appropriate or not. And so you tend to oversell when you're starting out. You tend to go, oh no, this is amazing. Oh, it'll last the rest of your life if I kill you soon. All these sorts of things. So you're going to overpromise and then you can't deliver that. And then because you feel guilty, guess who pays for the repairs? The patient? No, it'll be you, okay? I don't like paying for dentistry, okay? I'm a dentist. I should get paid to do dentistry. I shouldn't pay to do it. So this is one of the most important things to tell the patient. Your dentistry will wear out. It will not last you a lifetime. Even my practice, if you've seen my case and my patients, lots of my patients are 70, 80, even 90 years old, not for full mouth rehab so far, but I do have many patients in their 90s. None of them would I say to you, this will last a lifetime unless they've got 3 months to live, okay? Because people live a long time, a lot longer than dentistry lives for. We do have tougher materials, okay? Not stronger, but tougher, okay? Emax is not the strongest, lithium disilicate is not the strongest material around, but it is very tough. It's resistant to fracture, okay? If we go to zirconia, it needs to be thick. So one of the problems we used to have was that we had porcelain fused to zirconia. You would get a crack in the overlying porcelain, which would create a massive stress concentration. It would travel down and hit the zirconia. Now, how thick does zirconia have to be to stop a fracture? It has to be about 1 millimetre thick. So for zirconia to resist fracture, it needs to be at least 1 millimetre thick. If it's less than that, then it will fracture quite easily. So that's the difference, is it's not, zirconia might be stronger than Emax, but it's not tougher. In this particular patient, what I should have done is recontour or done orthodontics on those lower teeth. Now, I didn't know how to do ortho then, So it's very uncommon to do something if you're not really comfortable with it. So back then, didn't know how to do it. I could have just recontoured the teeth, so gone along with a burr and taken off all the sharp edges, maybe done a little bit of composite to flow out the edges so that the teeth were just a little bit less pointy. We'll go into another case. Here's another case. Now, I want you to look at this patient. Does she have masseters? No. Does she have a square face? Definitely not. She's got a slim face, an elegant neck. So she doesn't probably have a lot of sleep apnea issues, and she doesn't. So I would say just looking at her face, her mechanical risk factors are low. And not surprisingly, when we look in her mouth, we see teeth that don't have a lot of wear. They have wear, which is what you'd expect for a 60-year-old, but not a lot of wear. Okay, some of the back teeth still have the original anatomy. If you look at these lower teeth here, the teeth still have the original cusp shapes and inclines. Very little wear indeed. So not a worn dentition case. It was a full mouth rehabilitation, but not a worn dentition case. She has no biological risk factors, no tooth decay, no periodontal disease. So this is a case where our overall risk... Now, I'm still going to tell her it will wear out. It may not. I'm happy to be wrong in that way. I'm happy for things to last much longer than I said, but I'm going to tell her it will wear out. You will need to pay for repairs. Your implants will eventually give problems. The screws will come loose, all these sorts of things. And most importantly, on our consent forms, it tells the patient how much all of these things cost. It tells them how much is it going to cost if your crown breaks. It tells them how much is it going to cost if you need root canal therapy after you've had a crown. It tells them all these costs. If you want the consent forms, they're on the Academy. I'm not sure if they're on the free section or the premium section. Gail's over there. Do you know? Is it on the free section or the premium section for the consent forms?
There's one on the free.
I think that one of the consent forms is on the free part of the Academy. The rest are on the paid section. So our consent forms are all there. I have consent forms for perio, crown and bridge, implants, and all this sort of thing. And I go through them. It's very important that you tick. Realistically, okay, we'll do all this consent stuff. You'll feel very good about it. But we always forget, no matter what you say about lawyers, there's many of them and they're very, very smart. If they can find a new way to interpret the law that no one else has ever thought of, including our medical defence societies, they will. So we don't usually get sued for the same way that people got sued and now we all defend. We're going to get sued for some new way that we haven't thought of yet. So do all this. It probably won't change your risk of being sued one bit, but it'll make you feel better until you get sued. Okay. Now we can see this patient. I've gone through, done the full rehab. Think about the risk. The risks for this lady are very different to our average worn dentition. Her mechanical risks are low, biological risks are low, chemical risks are low. So realistically, the only thing we need to warn her about is, I always warn them about root canal therapy. Most times when I do a large case, even if I think they need if I'm not sure if the tooth needs a root canal, it gets put in the treatment plan. If I have a big treatment plan and I don't think they need any root canals, I might just throw one in because I can always not do it. So I might just choose a tooth with a deep fill and go, that tooth needs a root canal. And then if it doesn't, I've still got one root canal therapy in the treatment plan. And if they need it on a different tooth halfway through treatment, we can do that. Most importantly, my consent form tells them that if you get problems after you get the crown on, this is how much it will cost. And I also talk about this. So you'll notice I start to talk about all the things that can go wrong. Your teeth can break, your crowns can break, your crowns will wear out. They won't last you a lifetime. Even though it's very expensive, it's not going to last you a lifetime. And what I tell them is, depending on whether they believe in God or nature, your teeth, your natural teeth haven't lasted a lifetime. My artificial teeth will not. It's like getting an artificial leg. You've had your leg chopped off. You can get the fanciest, most technological carbon fibre leg. It's still not a real one. Won't last as long as a real one. Okay, let's do another one. This patient here, you can start to see he's a bigger man, okay? He's got a bit more power. You can't really tell this because there's not really anything to compare until you don't have something there for size, but he is a big man and he's got quite a robust head, okay? If you know what I mean. He's got fairly robust bone structure, fair bit of muscle. So immediately when I look at this, I'm thinking this patient has more power. It's not whether they grind or clench or not, it's just how powerfully they do it. Everyone grinds their teeth. I've never had a patient where if I make them a bite guard, they don't wear it over the years. Okay, so everyone does it. It's just how hard or how furious. So we can see that he's got decent sized masses. They're not bulging way out like bodybuilders, but they're definitely there. But what is important is he's not got a square jaw. This is the really high risk ones. This one's with a square jaw. He's mesofacial. He's not dolicho. He's not brachyfacial. He's mesofacial right in the middle. Lowers his risk quite a bit. Okay. Now you'll see that when we get to the case that he has got quite a bit of wear. Okay. You can see he's got a deep bite. And when we look at his teeth, you can see wear. Interesting wear pattern, hardly any on the back teeth, lots and lots and lots towards the front. So the complete opposite of the patient who had reflux. This patient doesn't have reflux, that's why he has no wear on the back teeth. No history of acid attack that we know of. So it is pure mechanical attrition. He grinds his teeth and he comes up onto the front teeth. Now, one thing I look at is the patient parafunctioning or grinding in sort of a horizontal way or more of a vertical way? But I've been thinking about this. I think sometimes it's a bit false because in general, the patient who grinds like this, we're more concerned about. But if you have a deep bite, you can't grind like that. You tend to look more vertical just because you have steep guidance on your front teeth. So now the funny thing is, of course, if we make steep guidance on the front teeth, the patient is more likely to chip their front teeth. My best cosmetic cases, the ones that have held up the best, are patients with contact only on their second molars who have an anterior open bite. So molar guidance. Do they have any more issues with condyles and TMD and things? I'm not sure, okay? Now, don't go home and start putting big composites on the back teeth to jack them up so that you can do veneers and have them last a long time. I'm not telling you that. I'm just saying that we have a thing on canine guidance or anterior guidance, which is also the teeth we want to look pretty, okay? So we're a bit at risk of, as we create canine guidance. Actually, my first veneer case, patient had flat teeth. Now, I would now look at him and go, he's massively risky, he had massive jaw muscles. Everything was worn flat. Everything, there was no cusp left. It was just flat. Horizontal parafunction, probably had sleep apnea. I think he had a square jaw, but I can't remember for sure. What I do know is I recreated canine guidance, putting nice little pointy canines on with feldspathic veneers, and they all cracked within a week. And then I redid them the week after. Lost a lot of money on that one. You can see here, a lot of wear on the front teeth, not so much on the back teeth. So we would say that he's fairly high risk. This is the actual rehabilitation that we did. It was my first time using Emax for a full rehabilitation. And it's one of the reasons I like Emax so much. Lithium disilicate has been one of the most low maintenance materials in my office. We did all of this. Actually, this is, I think, about a 7-year or 7-year follow-up. And here's his front teeth now. One thing you will notice, I did an implant where he had that massive abscess. This is a very common problem with single implants. Over time, the maxilla continues to downgrow. It grows down, and it rotates. Okay, it tends to grow down and rotate, so it tends to lean backwards. The implant stays the same. So well over half of the implants that I've done that have been there for more than a few years are showing signs of it. The very first implant I did is showing signs of this. Lots of my elderly patients 60s, 70s, 80s, after 5 or 6 years, they're starting to show that the implant tooth is a bit short. Now, remember, 1 in 5 teeth that you do a crown on gets an abscess. Ta-da! No, it doesn't, okay? We've done a crown on every single tooth there. This is many years post-op. Not a single abscess, not a single pathology, not even a radiolucency. What is important is I didn't go near the pulps. Because I increased the vertical dimension, I had plenty of room to avoid the pulps, and it also had benefits. So we can see the risk factors for this patient, mostly mechanical. There was no chemical risk. There was really no biologic risk. He had no perio. He had no caries at all. His risk was entirely mechanical, just grinding the teeth with a fair bit of strength. How do we manage it? we use tougher materials, so Emax. I wasn't doing it then, but what I would do now for sure is I would discuss the cost of repairs. Having said that, he hasn't had any repairs in the time that I've done it. Most importantly though, we have that deep bite and we increase the vertical dimension. When you increase the vertical dimension, open the bite up, the guidance becomes less steep. So they're not having to go down like this, they're coming forward. It means that the teeth, as they move about, they're not putting as much tension on the materials. They're not putting one tooth against another and bending it. Ceramics don't bend very well, so as soon as you have things hitting against each other with nice firm contacts, then you're more likely to break. So we want things just flowing smoothly over each other. This is my uncle. Came in, he had a lot of wear. In fact, his masseters were so exciting, I took a picture just of them, okay, just of the masseters. They were huge. Okay? He's got huge, and yes, he's breaking facial. So we're starting to get some really bad risks going on here. He's got a really square jaw. The problem with a square jaw is that the masseter tends to angle forward a lot more. So the force tends to be much more anterior, and because the jaw is shorter, you get a lot more power. So you've got a bigger muscle, smaller jaw, you have a much more powerful movements of the jaw, and you often have an anterior movement, which is why you often end up with fairly severe wear of the front teeth. Now, on top of this, of course, he'd had some dietary issues, so had lived in a country for a fair while where they have a very acidic fruit that's very, very popular, more acidic than lemon, and lost huge amount of tooth structure, okay? Also lost posterior support. Yes, he's got a partial denture. Partial dentures don't offer very good posterior support because the plastic teeth wear, and also because you can't put a lot of load on a denture before it hurts. If you put too much load on it, then they're getting ulcers all the time. So you tend to adjust the denture teeth. So essentially he ended up with all of his load on his 6 front teeth in a case where he has acidic diet. We have biological risk factors as well. He has tooth decay, no periodontal disease, but definitely tooth decay, huge mechanical risk factors, and we've had chemical ones. So we've had everything here. How do we assess the risk? For a patient like this is a patient where you just have to admit that they're going to break stuff. They're going to break the crown. If they don't break the actual crown itself, they'll actually snap the tooth off. You're going to get things break. Now, you will do everything you can to avoid this, okay? But the risk, mechanical risk, it's off the chart, okay? It's so high, you need to concede defeat. They're going to break things. Try and keep teeth in these patients. Because if you think they break things bad when you have teeth there, they break things worse when they've got implants. You know, they've got no proprioception and it's just a solid thing against a solid thing, very much more likely to break things. So we've got a lot of things how to manage risk here. Okay, the other risks are quite low. He doesn't have fruits that are acidic now. Biological risk, I think, is under control. He does have tooth decay, but I think we can manage it. But the most important thing is you tell the patient, you will break things. You will break things. It will cost money to repair. So you must be able to afford to do it, and you must have some money left over to repair it. This is a problem when people borrow money to get work done. If they borrow money to get work done and then they have nothing left, it's much more stressful if something goes wrong. They're much more likely to be angry. And most importantly, it will not last the rest of your life. It's not, oh, it might, it won't. Definitely won't, okay? If it does and you get lucky, great. That's a great way to be lucky, okay? But don't be telling them it'll last a lifetime and then you've got to send the hitman out because it's getting to, its teeth are about to fall apart. You think, oh, I've got to keep my promise, okay? On top of this, we're going to increase vertical dimension. As we increase the vertical dimension, then the guidance becomes less steep, okay? So instead of having teeth that overlap a lot, we've got teeth that overlap a little. We want more back teeth. So in this case, we did implants in the back teeth because we need as many teeth to share the load around. We don't want all that load on the front teeth, which meant in this case, implants. Okay, we want tougher materials. We don't want partial dentures because they don't offer enough support. 30% of people don't wear their partial dentures if they're not involving a front tooth. It increases his biologic risks of tooth decay and gum problems. Obviously, we want to get him in a bite guard, and a patient like this, we want to do everything. We want to check his sleep apnea, see what we can do. Maybe if we can improve his sleep apnea, then we can reduce the forces. We can get a bite guard, we can reduce the forces. Share the load on more teeth, we can reduce the forces. Have shallower guidance, we can reduce. All these things reduce force. He'll still break the teeth, but hopefully not as fast. And then on top of everything else, when there's biological risks, when we've got implants, we want regular maintenance. Implants do much better with regular maintenance because you can pick up problems early. Okay, once they start to get any sort of inflammation, maybe in 6 or 7 or 8 years, you can get on top of it very quickly. Now I'm going to show you a very different type of case, and you'll see how the risks are different. So if we look at this patient here, we can say, yes, he does have wear. The patient was 71 when I first saw him. Okay, when we look at the back teeth, we see, yes, there's wear, there's possibly a little bit of acid erosion happening there. On the lower teeth, we definitely see acid erosion. He had reflux, which is now under control. There's also signs of some sort of mechanical wear, so the grinding attrition or from grinding or clenching. We see here, that's classic erosion, that's erosion. So we're hoping that it's mostly erosion because if you control erosion, then it doesn't affect your dentistry at all. Much more difficult to control mechanical factors because they're always there. But most importantly, when you look at him, he doesn't look big and bulky. He's quite a slim man. He's got, slim neck. Muscles are not too big. He has got a square jaw, but he doesn't have huge muscle power. So the forces are much lower. We start to see these risk factors before the patient sits in our dental chair, just talking to them. This is 9 years post-operative, so we can see he actually went away. He comes in every 5 years for a checkup, whether he needs one or not. This is the teeth after this many years. You can see there's wear, similar sort of wear patterns to what he had before, but it's not very severe. On the upper, the teeth still look good, crowns look good on the lower. So patient with much lower forces, and everything lasts much better. So you can start to see that a lot of times whether our dentistry lasts well or not, we've got nothing to do with us, okay? It's got everything to do with the patient. I had very little idea what I was doing when I did that case either, but it has lasted well because the patient is gentle on his teeth. Now, for those of you online, you would have seen this case. This guy, these jaw muscles are just monstrous, okay? You just look at the side of his jaw, huge muscle, okay? Not surprising, we've got wear. Not much on the back teeth. I don't think there's much. He's in earth moving, so maybe there's the dust, dryness issue that we were talking about. Deep bite, so we've got really steep guidance on those front teeth. It's going to put a lot of force on the front teeth. We've got jagged lower teeth. So when we think about him, risk factors, his mechanical risk factors are super high, okay? Very, very high. His chemical risk factors are pretty high because he had reflux in the past. I think he has it treated now. So it's coming down, but it was high. I don't think the reflux was a big issue, though. I think the big issue was the grinding because he doesn't have as much wear on the back teeth. Traditionally, when you get bad reflux, it's mostly on the back teeth. So I'm thinking it's mostly muscle power. Low biological risk, has no tooth decay, has no gum disease anywhere. He hasn't had his teeth scaled in 8 years. I've sent him off to get his teeth scaled just because I don't like to work on teeth that look yuck. But really low risk factors there. This is the case after 8 years. So I did all that work on his front teeth. I did crowns in the front teeth. And after 8 years, we've got significant wear of all the actual metal on the back of the porcelain fused metal. It's heavily worn. We've had some things break. Okay, and the lower crowns worn all the way through the porcelain in 8 years to the metal. Worn all of the front crowns almost down to the zircon, down to the metal. And you'll notice the wear pattern is exactly the same. So this patient, now, this particular patient, I haven't gone through, but how will I manage his risks when I redo his case? As far as he's concerned, it's a success. In fact, that first patient I showed you where 8 of the crowns broke, It was a success too, because the patient says, I haven't had a root canal since. So even though he's had crowns breaking, from his point of view, he's had no root canals since he was nearly wearing into the pulps. So he's happy. This patient has had no dentistry, not even a checkup for 8 years, and he had all sorts of problems beforehand. So he's happy. So it's not a failure, it's just wear and tear, okay? He has earth-moving equipment, so he wants to buy a thing that costs $5 million, so this is not too dear, okay? So how do we manage the risk? Most important, tell every patient that you're doing these big cases, if they've got wear, it will fail unless they die. Have consent forms that have the cost of failure. That's very important, because if you don't get them to be understanding the cost, if they're not ready to pay for the repairs, then you'll have to repay. You'll have to pay for the repairs. Make your guidance shallow, use tough materials, spread the load on as many teeth as you can, and most importantly, wear a bite guard. Okay, so that's this session where I've talked about assessing risk and managing risk of the worn dentition. The next webinar, I will talk about how you actually plan to get the aesthetics and the occlusion and so on when you're getting the wax up in the actual initial stages of the rehabilitation. If you have questions, send them through. I'll be happy to answer them. The replay of this will be on the Academy in a day or so, and you'll get a link for that. I'm just going to go and grab my phone and I'll get some questions. Let's see what you got. Okay, I have many questions and they're long ones today. Okay, I've got many questions. Nabaz asks, how much time will it require to get a stable deprogrammed jaw relation if we want to get a new centric relation on such worn cases? And then brackets, it says on average. Now remember, averages are completely useless because none of your patients are average. So it's like, you know, the average speed that I drive at is 68 kilometres an hour according to my car. That does you no good in a 50 kilometre an hour zone, and it does you no good in a 100 kilometre an hour zone. Average is 2 or 3 weeks, okay? Most people, if they wear, that's with a segmental device. That's a bite guard they wear at night time that only sits on their front teeth. If you have a full arch one, I think it will take much longer because you've got to adjust the back teeth, and then you've got to adjust the back teeth, and then you've got to adjust the back teeth, who knows how many times. So if you, almost all deprogramming bite guards are segmental, which means that they are only on the front teeth, and you remove all of the contacts on the back teeth. You only wear them at night time. In most cases, it will be 2 or 3 weeks. And you need to check. Now, Michael Melkers has a really good video on how to check this. You make a little bite. You make a little bite record. You get the patient to go chomp, 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 okay? And then you check it a week later and make sure it's still the same. And then you check it a week later. And if they're biting easily into the same position every time, they're stable. If they're biting into a different spot and they're not tapping straight into the same spot on the bite record, they're not stable. So you need to talk to Michael Melkers about that one. He's got a really good test on that. He has had a patient that took up to a year to become stable. So that's why averages are useless. Some patients might be 2 or 3 days, some might be 2 or 3 weeks, and some might be a year. So you have to basically test whether they have become stable by taking a bite and then checking it the next week to see if it's the same. Laura asks, what's your opinion on botulinum on masseter muscles? Okay, Botoxing the muscles is a great idea for some patients. The problem is that it wears off. So it can't be your main approach. You need to do everything else as well first, and then if you think it will help and the patient agrees, you do Botox. Okay, it's like bite guards. The patient, we know a bite guard might be perfect, but they might not wear it. So we always have to design the teeth as if they're not going to wear a bite guard and then make them a bite guard as well. So you would need to design the teeth and get them to wear a bite guard and do Botox, because they might stop doing Botox. It's going to last 3 months the first time and about 6 months the second time. I have had one patient complain that when she had Botox, she couldn't chew very well, and so she didn't want to get it again. Masood asked, Dr. Ling, about cupping lesions and wear occurring underneath onlays if they are supragingival. How would you avoid this happening? So I think what you're talking is class 5 lesions on the side of the teeth where the onlay comes down the side of the tooth and you're getting acid erosion on the side of the tooth and it's undermining the restoration. Those sort of cases, first of all, you're going to have to control the acid before the patient gets restored. And in those patients now, I actually tend to do a vertical preparation or a subgingival margin so that the crown actually goes well past the erosion lesions, because too many times I've had the entire side of the restoration get undermined by the class 5 lesion. Laura's back. She says, would you do posterior implants on patients with anterior teeth wear? This patient of mine has prominent masseter and he grind anterior teeth and is also missing 3/6 and 4/6. Okay, so when it comes to treatment planning, I refuse to treatment plan for you unless you send me full face pictures, smile pictures, retracted photos and occlusive photos. So I don't treatment plan without photos. And the photos have to be good. Don't send me rubbish ones where they're all crooked and you can see up their nose and snot and stuff. I don't want to see that, okay? But yes, you can. The more teeth, if they've got a lot of wear on their front teeth, more back teeth is better. If they don't have enough back teeth, not everyone needs posterior support, but people who have a lot of wear on their front teeth usually do. Dima asks, how did the patient cope with increasing vertical dimension? For some reason, every dental student leaves dental school thinking that if you increase vertical dimension, the patient will die. They don't, okay? You can increase vertical dimension all day long. Every second patient, or actually every patient I do a rehab, almost every patient I do increase in vertical dimension. Anyone who's ever made dentures has increased the vertical dimension 3, 4, 5, 6, 7, 8 millimeters. If the patient can still swallow easily, you haven't increased it too much. So if you increase the vertical dimension, you want to test it, get them to drink. If they're sitting there going like that, then you've increased it too much because you can't swallow with your mouth open. If you haven't increased it that much, they'll be fine. But good question, because everyone leaves there. I left dental school thinking, oh, if I lift it 1 millimeter, the patient might die, okay? So far, in the history of dentistry, no patients have ever died from increasing their vertical dimension. Sophie asks, is there any advice you would give the young brachyfacial patients with large masseters to prevent extensive wear? Well, young patients, you can't tell them anything, okay? It's like young dentists, okay? They have to go and make all the mistakes themselves because they don't want to listen. So, yes, you should tell them wear a bite guard, blah, blah, blah. But, I find patients in their 20s, they're not ready to listen yet. So if they'll listen, then they probably don't have problems anyway. But if they have these big issues, you'll usually, if they do, they'll actually show significant wear already. Even in 20, they'll have lost 30% of the length of their front teeth. So, they have significant wear going on, even at very young ages. Anard says, some teachers advise to do the upper teeth with ceramic and the lowers with resin composite. What do you think? The only reason I would do that is if the patient can't afford EMAX everywhere. So there are some cases that are better done in resin, but if you do ceramic against resin, the resin's just going to melt away. It'll be gone in 5 years, particularly if they're one of these patients. So my suggestion is if you have a patient with big muscles and brachyfacial, put strong materials on the upper teeth and the lower teeth, and they're still going to break, okay? Mechanical risk factors, decreased vertical dimension. His presenting complaint was his anteriors concerning him, and he is travelling overseas in 6 weeks to visit his family, whom he's not seen in decades. Okay, so if the patient leaves it too late, that's not your problem. Okay, that's the patient's problem. If you want something done in 6 weeks, then do a composite overlay or, a mock-up, bonded mock-up or something. Give him instant teeth that look very fancy very quickly and tell him you'll come back and you'll start turning them into crowns. Okay? Part 2 of the question, he would like a full mouth rehab, but is aware that it may take time and may fail. That's right. It will take time, costs a lot, and it will fail. Part 3 of the question, he would like a temporary solution for his anteriors, which are shade A4. I'm reluctant to rush and do anything definitive. However, do you have any ideas? Help me. Okay, so what I would suggest is, first of all, send me a private message with photos, full set of photos, make sure they're good, or I will mock you privately. maybe privately. Send me a private message with all these pictures and I'll help you out. But if the pictures are rubbish, then I won't help you. So make sure they're good. If you can't take good photos, you can't do a rehabilitation. And last question, because it's now 9 o'clock and it's time for me to go to bed. Part 4 of the question. Leah wins the prize for the most parts to a question. Okay, we're going to do part 4, section 1, paragraph 2. As I'm aware that, even I'm just teasing you, Leah. It's a bit rude to tease you in front of thousands of people. As I'm aware that even with full treatment, he'll break things. Cost is not an issue. Yes, he'll break stuff. You just got to tell them that. Look, they'll break it. Patients will still go ahead with treatment, knowing, actually just think you're honest. You go, look, I'll do all this stuff and you'll break it bit by bit. Usually it doesn't all collapse at the same time. It's like my first patient. They break one tooth here and then they break one there and they break one here. And, you know, it's wear and tear. It's like tyres, okay? Wears out. Okay, there's a stack more questions. What I'll do is I'll do a video tomorrow or the next day, whenever Gail grabs me and makes me do it, to answer the rest of the questions. So if you have more questions, send them in. I'll answer them later in the week or next week and do a video and put it up on the Academy for you. Thank you so much for watching. I enjoyed it very much. Hope you did. And next webinar, we'll continue with worn dentitions, a bit more on how to actually plan the vertical dimension and all that stuff. Thank you very much.